We are doing a final audio check in Kofi Annan before we start. Final audio check. 1, 2, 3. So this is just a gentle reminder to everybody to please mute your mic when you're not talking. And also, this is to confirm that we will be starting to record in the next 5 seconds.
Okay, we are ready to start. Even if one of the speakers is still not connected, I suggest, Laurel, you take over and we formally start the meeting, please. Thank you.
Have we opened the meeting to the participants?
Yes.
Okay, good. Okay, thank you, Jacek. Thank you and welcome to everyone on the call. My name is Laurel Sprague. I know many of you and look forward to hearing and getting to know those who I don't yet know. I lead the Community Mobilization Division at UNAIDS headquarters in Geneva, where many of us are broadcasting from today. One of the beauties of working virtually, though, is that we've been able to bring in really an incredible group of speakers and participants for this dialogue, much more than we ever would have been able to do in person. So first, let me welcome, with a really warm welcome, all of our speakers and participants in this webinar. I'm really looking forward to hearing the speakers and the discussion that will follow. Just a few notes to begin. Probably most importantly, there is interpretation available on this webinar. Hopefully, if you're hearing me in English, you can still follow this. You can go to the interpretation button at the bottom right of your screen and select English, Spanish, or French interpretation. And I hope perhaps someone could post that in the chat box in case there's anyone who doesn't understand me in English sharing this information. So we're looking forward to having this multilingual conversation together. I'll talk about the objectives and we'll start the first panel in a moment. First, I just want to talk a little bit about how the process will go. So first, I should say this is a webinar put on together with UNAIDS, PEPFAR, and many good colleagues in the faith response to focus on spirituality, mental health, and resilience, especially as it relates to HIV and COVID, the HIV and COVID pandemics. And what I would expect is that not only is this relevant for the communities that we care about and work closely with, but probably also relevant for every single one of us who has joined this call. We're not separate in the challenges we face from the challenges that the people we care about are facing. And I hope we can bring our whole selves, our whole perspective and experience to the conversation so that we can have a fruitful and grounded dialogue together today. I will ask you to mute your microphone when you're not speaking so that we can have the clearest sound possible for everyone. We're all connecting with different kinds of connections and different levels of Wi-Fi. So we want to make it as easy as possible for everyone to be able to hear and participate. You will hear two panels. Each one will be approximately 45 minutes to an hour in total, with speakers and dialogue, question and answer, and dialogue together after the presentations. while the presentations are happening, please make use of the chat box for questions and comments. And you can put those questions and comments while speakers are presenting. That way we can try to have bring in as many comments and as many different voices as we can. So feel free to make comments and ask questions throughout the presentations. And then we'll have time for Q&A after. Also in the chat box, if you have key recommendations to take forward, please type those into the chat box. And again, you don't have to wait to the end. At any moment that these key recommendations might come to you, please just go ahead and add them. We'll be collecting all of them, and that will help us have a good record of the conversation, but also to take it forward so that we're not just having a dialogue here today, but we're actually able to move forward an agenda that supports and cares for people, particularly around mental health, and resilience and spirituality in the face of the two pandemics that we're facing. You hopefully have seen the Interfaith Health Platform website. All of the recommendations and the notes from this meeting will be posted. The materials will be posted there after the meeting, not directly after. Give us a little time to organize those, but then you'll have access to all of that as well. And so having said that, let me briefly go through the objectives, and then I will introduce our first speaker, and we will start to move through the panel and get into the heart and soul of our conversation today. So you see hopefully on your screen the slides for today, and we have 4 objectives. First is to raise awareness together. I think we are aware, or we wouldn't have so many people. We've had almost 300 people register the last I heard. So I think there is a great deal of awareness that we can share with each other among faith leaders, groups, and faith-based organizations on issues related to mental health that are faced by people living with HIV and have been exacerbated by COVID-19. Second objective is to better understand what a human rights-based approach means and why it matters for faith groups to adopt it to improve HIV and health outcomes, well-being, and quality of life. Third is to talk about what spirituality and resilience can offer us as a framework to improve the quality of life of people living with HIV during COVID-19, and also for a more effective HIV response more broadly. Fourth is to present best practices and lessons learned by faith leaders and groups. And finally, as I've mentioned already, to identify key recommendations. And we really rely on all of you to help us gather those key recommendations. With that, I see people are introducing themselves also in the chat. We really invite you to do that, as unfortunately we don't have time to do wide introductions. So please go ahead and introduce yourself in the chat box if you haven't already. And thank you to those who have. So let me go into the first session. I'll be the facilitator for session 1. We have, as you can see here, 4 very interesting, committed speakers that I think I'm really looking forward to hearing. I'm sure you are too. Let me do quick introductions for each, and then we'll go as quickly as we can between each presentation in order to save some time, as I've mentioned, for discussion and dialogue here. So our first speaker will be Danius Puris, who is the director of the Human Rights Monitoring Institute and professor in the Department of Psychiatry in Vilnius University, also the former UN Special Rapporteur on the Right to Health. And he'll speak on a human rights-based approach to mental health. Next, we'll have one of my UNAIDS colleagues, well-respected colleagues, Dr. Anna Shakashvili. And Annie, and she will speak about mental health and HIV, and a number of areas related to that. Third speaker in this first panel is Reverend Sarah Lund from the United Church of Christ Ministry for Disabilities and Mental Health Justice, speaking on spiritual care tools for community mental health. And then the fourth speaker on this first panel will be Dr. Sabrina Cherry, who is who has an interdisciplinary qualitative studies certificate, which is something that I'm jealous of, actually. I was reading about that earlier, and is the assistant professor and public health faculty fellow at the University of North Carolina Wilmington Center for Social Impact. And her talk will be on the impact of spirituality on resilience and coping during these pandemics. So let me now turn the floor over to our first speaker, Danius Puris. Looking forward to hearing from you, and hopefully your slides are ready to go. So sir, I give you the floor.
Thank you. Thank you for this invitation to join very timely and meaningful event. I will be sharing my experience of 6 years. Just a few months ago, I finished my 6 years of tenure serving as a UN Special Rapporteur on the right to physical and mental health, and one of my priorities was mental health. So first slide is about momentum. Why mental health? As you know, mental health now is increasingly recognized by global community. It started with SDGs and Agenda 2030, because in MDGs we did not have mental health at all. And now it's clear that mental health should move from margins to center of health and development agenda globally. States are urged to invest more in mental health care. This is global agreement. There is not full agreement about how to move, how to invest, and how to not invest. And especially with COVID-19, we are in very interesting debate about how what changes are needed in mental health and mental health care. And here, human rights-based approaches is crucial. As we know, there is an unacceptable situation with violations of human rights of persons who need and who use mental health services. And this is not only because of lack of resources. Of course, this is an issue, but this is something wrong has gone with attitudes with regard to mental health services. And now all stakeholders should rethink their position on important issues and their role. And my position, and you will see in the next slide, was critical about status quo, and that we should more fully embrace human rights-based approach, as we did with HIV and other health issues. So in my reports, I emphasized the systemic issues in status quo, such as overuse of biomedical model and interventions. Not that they are not needed, but they're overused in many parts of the world. As also what is overused is power asymmetries between service providers and users, so that psychiatrists quite often still being too paternalistic, and only with medications you cannot empower people. Often such paternalistic approaches, they disempower. And then also biased use of evidence and knowledge when professionals and policymakers are still informed that the main idea is to fix disorder in the brain, and this is not really the main issue. So there is a need of change in mental health laws, policies and practices, with the aim to fully address human rights-based approach within mental health services and of course beyond mental health services. So my message is mainly that if we only invest in existing status quo, which is a lot of closed institutions and very medicalized approach, we only reinforce the vicious cycle of discrimination and empowerment. And my next message is about change. So what change is needed? Can I see the next? So there are many parallels between different public health crises. We can learn a lot from HIV epidemics, and measures now aimed at preventing COVID-19, for example, should not discriminate groups in vulnerable situations. As we know, children and women are at increased risk of, for example, domestic violence. So we should be aware of this and take actions, because this is detrimental also to mental health. Good mental health, and I want to highlight this, is mainly about good quality of relationships, in other words, social determinants of mental health. So if we invest effectively in solidarity, in trust, in resilience, in good non-violent relations, these are mental health equivalents of vaccinations. So we should start from early childhood, which is what is called now advanced childhood experiences. And when we address such issues as depression, for example, we should more speak about how to prevent power imbalances, which is again about social determinants, rather than only highlight chemical imbalances in the brain. So psychiatry and mental health care should learn painful lessons from history when human rights-based approach was undermined and the principle of first do no harm was undermined. Interestingly, my experience, because my mandate was global, so I was traveling to all regions. Global South, this is encouragement for Global South, can be more effective, can be more open than Global North to innovative rights-based practices. And many modern cultural practices that support, respect, and empower people can be very effective, even if country does not have so many mental health professionals. Of course, we should differentiate and abandon those practices which are disrespectful, which are discriminatory, and they are so-called harmful practices. Next message is about, can I have next? Is about some examples of avenues heading towards change. So main principle applies to mental health as to other issues. To promote good mental health of everyone, we need to address social determinants, and we should address inequalities, injustice, all forms of discrimination and violence, because all these are detrimental in the long run to mental health and well-being. States need to invest in enabling non-discriminatory and non-violent environments in all settings, so family, community, workplace, healthcare services, and mental health care services should be free from violence, and of course society at large. Critically address excessive pathologization of common mental health conditions, especially with COVID-19. So if people, adults and children, are anxious now and in these times, so should we pathologize this? This is normal reaction. Of course, we have to think how to support these people, but not to move to medicalization and pathologization of these conditions. So we should prevent medicalization of human diversity and misery. And of course, support persons with psychosocial disabilities by fully implementing Convention of Rights of Persons with Disabilities. And as we know, there are still too many people locked in institutional care in many parts of the world. And especially now during COVID, you know that these places, they were harmful already before, but now they're becoming hotspots for contagion. So it's high time for moving with passion and science to community-based services. Crucial role of civil society and experts with lived experience. They are not West, they are the same good experts as psychiatrists and other mental health professionals. And I would like to draw your attention to powerful resolutions of UN Human Rights Council. So it's not that only special rapporteur was sending these messages, but 3 resolutions from 2016, 17, and 20 on mental health and human rights are very, very firm on human rights-based approach to mental health. And also WHO Quality Rights Initiative is very, very, very useful. And I'm moving to conclusion. Can I have the last? So again, about these parallels, HIV, COVID, but also so-called epidemics of poor mental health. So what are the common denominators? There is no hierarchy of rights. Indivisibility of all rights is crucial in this approach to human rights and mental health. If we want to somehow to address human rights abuses in mental health systems. All healthcare services, including mental health services, as it was with HIV epidemics, should be free from discrimination. And COVID-19 pandemic offers a unique opportunity for mental health services to abandon outdated practices and to fully embrace human rights approach. My last is what was told by Jonathan Mann, and I was using this quote very often, and those who work in the area of HIV, of course, know Jonathan Mann, and it applies to COVID and it applies to HIV and mental health. Can I have next? So the human rights framework provides a more useful approach for analyzing and responding to modern public health challenges than any framework thus far available within the biomedical tradition. So we should send message to all stakeholders about human rights-based approach being a very useful tool and very useful method in addressing issues related to physical and mental and all health. And those who are interested may find more in my reports and in resolutions of Human Rights Council. And there are links in the end of my presentation. Thank you for your attention.
Danius, thank you so very much. What a breath of fresh air, I'm sure, for all of us to have this presentation to launch our discussion today, and particularly the attention to mental health being about good quality of relationships, about not medicalizing human misery, human diversity, the importance of lived experience and bringing care to people where they are. I took so many notes. I won't go through them all again, but really, thank you very much. I think that was a really powerful and important way to frame the conversation we are to have now. So really thank you. And let me turn next to our own UNAIDS colleague, Annie, to talk about mental health and HIV. Very much looking forward to your presentation. And I will turn the floor immediately over to you.
Hello to everybody. Thank you, Laurel, so much. And thank you and Jacek for this great opportunity to be able to join you all. And thank you, Mr. Danius Puris, for this amazing introduction, very much like also challenging call for what we really need to do together. And particularly, I'm thankful for Jonathan Mann's quote, my personal hero and role model. Today, I would like, in a very, very brief way, to really give an overview around mental health, but also substance use and HIV interconnectedness, more coming from what we at UNAIDS value and are committed to, which is through promoting human rights and integrated, people-centered, community-centered approach to improving HIV and health outcomes, well-being and quality of life. So if I may have next slide, please. In 2016, the Global Burden of Disease Study had estimated that approximately 950 million people around the world experience a mental health condition and over 162 million drug or alcohol use conditions. That is in total of over 1 billion people, or 16% of the global population. Close to 800,000 people die from suicides annually, a majority of which are associated with mental health conditions. Suicide is now the second largest killer of older adolescent girls worldwide, following maternal mortality. And suicide is the second leading cause of death among young people aged 15 to 29 years globally. So mental health conditions, including most frequently depression and anxiety, occur very commonly among people with HIV or affected by or at risk of HIV, and often at higher rates than those without HIV or without HIV vulnerabilities. For example, in some countries, prevalence of depression is as high as 80% among people living with HIV. In sub-Saharan Africa, it's estimated that 24% depression prevalence is among people living with HIV versus 3% in general population. People with HIV die by suicide more often than those without HIV, and there is also a high risk of dying among people living with HIV with mental health conditions, especially with severe ones such as schizophrenia, compared to those without mental health conditions. People who use drugs and those with harmful use of alcohol are at significantly higher risk of HIV infection. Mental health conditions and drug use and dependence affect access to life-saving HIV treatment, as well as HIV testing, adherence to HIV treatment, and reaching viral load suppression, and therefore their HIV and other health outcomes are significantly impacted by that. Next slide, please. HIV is associated with certain neurocognitive disorders, such as, for instance, dementia. HIV treatment can cause mental health related side effects. Both mental health conditions and HIV share common social determinants, and thanks Mr. Pures for mentioning that earlier. And among those are violence, including intimate partner violence, poverty, unemployment, stigma, discrimination, displacement, marginalization, and people with both mental health issues and HIV or drug use and HIV often face double stigma, including within healthcare facilities. Groups particularly vulnerable to mental health issues are adolescents and young people, elderly, key populations, racial and ethnic minorities, migrants, and those affected by conflicts and humanitarian crisis. So we're talking about also live course approach, age, locations, and context and local specifics and vulnerability. Approximately, for instance, 50% of mental health conditions present in adulthood begin by age 14, and 75% begin by age 25, as an example. Next slide, please. There is also a bi-directional relationship between HIV and substance use. More than half of the people who inject drugs are living with a viral hepatitis C, and 1 in 8, approximately 1.3 million people, are living with HIV. Alcohol consumption associated with HIV risk as well, and HIV mortality, according to the last, really amazingly great global status report on alcohol and health from WHO, reports on alcohol causing an estimated 33,000 deaths from HIV/AIDS, representing 3.3% of all deaths from HIV/AIDS. So the alcohol and HIV medications, interactions, and toxicity, and the risk of resistance to antiretroviral drugs are also well documented. Next slide, please. Now, addressing the bidirectional links between mental health and HIV, as well as substance use and HIV, are both an imperative and an opportunity for ensuring both physical and mental health of people living with HIV, affected by and vulnerable to HIV, including those also with mental health conditions, drug dependency, with harmful use of alcohol. So management of the mental health conditions and substance use in the context of HIV service provision and care can help improve access and uptake of the HIV services, including adherence to antiretroviral drugs, but also longevity, physical and mental health. Therefore, integration of approaches and interventions and services, as well as addressing the policy, strategies, systems of health, including strengthening community systems, among those that are faith-based, religious organizations, and so on, and remobilization of resources for that is just a real imperative. Now, for addressing both HIV and mental health issues, elimination of stigma and discrimination, as well as violence, coercion, and abuse is a must across the sectors. So our collective focus should be on human rights-based approaches to integrating people-centered, holistic, gender-specific, and age-specific prevention, testing, treatment, care, and support, including psychosocial support to people living with HIV or at risk or vulnerable to HIV, as well as people with mental health conditions, is an opportunity and everyone's obligation. Among many issues, the global scarcity of professional cadre with expertise in mental health and drug treatment or alcohol dependency treatment must be addressed. But there are opportunities, even in resource-constrained contexts or settings. Some of non-professional or non-expert service providers, community organizations, including faith-based organizations and so on, have taken these objectives on, and we've seen amazing number of great practices of integration of these services for most in need. Next slide. Let me turn now to the impacts of COVID pandemic. Billions of people are affected by this pandemic. Among them, all of you around the table, myself, my family. Billions of people are affected by this pandemic, which is having a serious impact on people's mental health, including of those affected by another pandemic, HIV, of course. And studies indicate that the pandemic has been and continues to be associated with distress, anxiety, fear of contagion, depression, and insomnia, as well as significantly increased violence and discrimination, increased levels of alcohol and drug use in various groups of populations and among healthcare and support providers. Bereavement, isolation, loss of income, fear, and not being able to access health services and support, as well as economic difficulties and uncertainty, can trigger and worsen mental health conditions. COVID infection itself is often characterized by mental and neurological manifestations and likely long-term neurological consequences from some. And the pandemic may increase, and the impacts of the pandemic has been among many suicide rates, including among survivors of COVID. So in terms of effects of the pandemic on people living with HIV or vulnerable to HIV have been really dramatic. For instance, food insecurity has been affecting health of people living with HIV and their families. We have seen increase in violence, including intimate partner violence against women and girls, including women living with and affected by HIV, as well as people from LGBTI communities following public health orders and lockdowns. We've seen disruptions of prevention and healthcare services affecting people living with HIV or at risk of HIV, as well as people with mental health issues and people who use drugs. And over 60% of the 130 countries surveyed by WHO reported disruptions to mental health services for vulnerable people and communities. 65% reported disruptions to harm reduction services. So it is critical that investments and collective efforts go towards addressing mental health in the context of vulnerabilities to both COVID and HIV, and in the response to and recovery from the COVID-19 pandemic. We have also seen many countries and communities, including faith-based organizations, including some youth organizations, implementing innovative multi-sectoral, multi-disease specific services and support, community-based approaches, including with psychosocial support, to ensure the continuity of services, including for mental health issues. And next slide. So countries should promote people-centered, gender-specific, age-specific human rights approaches for well-being and quality of life through the life course. Invest in integrating mental health, substance use services, and psychological and psychosocial support with HIV services. So this kind of integrated approach is a way to achieve also universal health coverage. So integration is feasible as mental health and substance use care and psychosocial support are not costly. It takes a will and some innovations to do that. Communities play a key role in responding to HIV, mental health, neurological and substance use issues, and now the COVID-19 pandemic also, despite all these tumultuous times that everyone is going through, is a good catalyst, as we have seen in many countries and many settings, to do that. And then obviously we need to mobilize efforts to address this shortage and lack of capacity of human resources, both on the specialist side as well as non-specialist providers of services, to be able to provide those kinds of support and services. And my last slide. And then in addition, of course, addressing mental health should be a key focus as countries emerge from COVID-19 pandemic and recovery efforts. And the role of community-based organizations, faith leaders, faith-based organizations is tremendous here. We still need to address gaps in knowledge and programming through additional epidemiological, clinical, and programmatic research. And then lastly, what I'd like to mention is there is so much more increased commitment to addressing people's to include in the strategies as well as the efforts more people-centered approaches. So one of the illustrations of it is the ongoing process for developing a new global aid strategy, within which we will see those approaches well and explicitly called for, including with integrated mental health, HIV, and other services and support for communities and individuals across the settings. We will have new global targets for 2025, including for mental health and HIV integration. And soon we would be happy to share with all of you a new guide that UNAIDS and WHO is developing for the ways how to integrate mental health into HIV programs and in between mental health and HIV. So thank you very much for your attention, and best of luck in all your endeavors. Thank you.
Annie, thank you very much for this. I think, among other things, you really emphasized the suffering that many people living with HIV have experienced. That's also it's often been invisible or just diminished or minimized. Plus some really important ways forward. It's really appreciated. We're a bit over time, so I am going to ask the presenters if you're able to respond to any of the comments directly in the chat. Just in case we don't have time for them to be asked publicly, please go ahead and do that if you're able. I know that Reverend Sarah Lund was having some trouble connecting. I just want to see, Sarah, were you able to connect? And I think not.
Yes, I've received the notice that I should be prepared to go. This is Sabrina, not Sarah. So yes, the presentation on the screen is the correct one.
Okay, super. So Dr. Cherry, thank you very much for being flexible. If Sarah does join, we'll have her presentation go last in this session, but really looking forward, Sabrina, to hearing from you. And then let me just, in the interest of time, just immediately give you the floor, and thank you.
Thank you so much. Good morning, good afternoon to some of you, and good evening to others. I am honored to be here and to present today. I'll be talking about our work, but in the context of how we can apply it to the practice-based setting. So please, next slide. And you can go ahead and forward to all the things that are on the screen. I just want to give a few disclosures that I am based here in Southeastern United States, as well as the Southeastern region of North Carolina. But I bring to my work lived experience from other places, from the Gambia, West Africa, from Wales, the United Kingdom, as well as living throughout the US. In that regard, my health broadly focuses on my work, broadly focuses on health disparities, but in a number of different aspects, including health and religion. And so the work that I do and what I'm talking about today is not only my professional endeavors, but is also very personal for me in terms of the work that we can do as a part of practitioners, researchers, speakers, organizers, program developers, and as members of faith-based communities. Next slide, please. And you can, yep, thank you. Here is an overview of what I'll be talking about today. I will not go into the explicit details of our research project, but you can find the article that we published on the webinar's resource page. Next slide, please. So just diving in, I want to give some context for how we define spirituality for our research project. Next. Many times we hear people say, I am spiritual or religious. And so we have this sort of sparsing out of spirituality and religion. So we tend to, in some regards, follow this definition that's on the screen, where spirituality is understood as this sort of broad or broader, in some regards, broader outlook of a deeper connection to oneself, to others, to nature, and or to God or to a higher power. Next slide. But I think there is room for us to consider what we see in the middle of the screen. So sometimes we look at religion, or those of us who prescribe to a religious sect, as, okay, we have this prescription of rituals that we follow. We have ideas, or we have someone telling us what we should be doing or shouldn't be doing, what is right, what is wrong, what is true, what is false. And at the opposite end of the spectrum, this sort of deep personal connection to nature or to God. But if we look at the middle of the screen, we see that there is room for overlap where people can absolutely be a member of a religious community and have a deep sense of spirituality and connectedness. And one of the many things that we can experience when we acknowledge this, even in our organizations, is a sense of awe, a sense of wonder, a deeper opportunity to be able to connect with people and to help them dive into hard things, just like dealing with COVID-19, for example, in the midst of living with HIV and other pandemics that we're experiencing. Next slide. So what about resilience? Many times when we think of resilience, we have the notion of something very beautiful emerging from really hard places. We think of the plant that we see on the screen and this sort of broken concrete, right? This flower that emerges in opportunities or in the midst of things that may seem challenging and even unexpected. Next slide. But what we tend to maybe fast forward or look over are this need to be able to recondition and to rebuild. So that resilience isn't just bouncing back from hard times, but it is work that we can help and empower others to do in terms of really understanding what we're experiencing. So understanding, for example, HIV within the context of COVID-19, and really being able to process that and then think about how we can empower and equip communities that we serve to be able to move forward. So not just bounce back, not this immediate or expedient sort of recovery, but really being able to process and work alongside other communities in the state of really hard things. Next slide. So for our specific research project, we were looking at spirituality and resilience and thinking about what does that lead to, or what does that produce, what does that foster in the midst of COVID-19. Next slide. Some of the things we were hoping, expecting to see are on the screen. Connectedness, values, etc., facing hard things. But we were also looking at community organizations, at researchers, to think about how we can support and provide resources that help people process and heal. So it was more than, once again, this sort of what we think about with spirituality, a personal connection, more than what we think about with religion, maybe a sect of rules and guidelines. But also, do you have the support that you need and the resources that we need to process what is happening, to heal from what is happening as we rebuild our communities, as we provide resources, as we evaluate tools, as we restructure programs, as we create new strategic plans? Do we have all of those things in place to be able to mobilize to move forward? Next slide, please. So our research article focused on spirituality and resilience during the time of COVID. Next. Few lessons learned. You can put everything that's available on the screen. As you may suspect, we saw with the members who responded, at least to our survey and to the open-ended questions, they did have notions of hope, right? That things would get better, that things will change, maybe even peace, that this is very challenging. This is a very hard and troubling time, but I'm at peace with what is happening. My faith and or my spirituality allow me or equip me to be able to do that. And even a semblance of comfort. Continue. But as you can imagine, even those, it wasn't mutually exclusive. So even those who experienced hope, for example, and peace, also talked about having feelings of fear and despair. And there's one more bullet point there. And doubt. So sometimes it was that people who scored lower on the spirituality scale said, yes, I feel these things, but it was also people who scored relatively high spirituality and resilience, also noting that they felt fear and despair and doubt. Next slide, please. So what are some practical next steps? As I mentioned, the research article is available on the webinar's resource page, but what are some things that we can do within our respective organizations and countries to really take what I think can be often big data from research to really apply it into the context of our communities? So one thing is considering how we can foster both spiritual growth and resilience with the resources that we have available. Digging deeper into our sacred texts that exist. And this is particularly for faith-based community leaders, right? So what are the texts that we have and how can we then, yes, I'm looking at the chat as it's coming up, how can we then dig deeper into those texts and make it applicable to one of the respondents who just mentioned this, integrating our lived experiences. So we ourselves are experiencing doubt and fear and concern and worry, being transparent about that with the communities that we lead, right? So not saying that we have to be the perfect model for the communities in which we walk alongside others, but that we can be transparent about what we're struggling with and how we're struggling. We can embrace the journey. We have been in this now approaching a year, some longer than that in terms of COVID specifically. HIV, a number of decades, right? 3 decades and counting. So how can we look at this as a long journey that we will walk alongside our community members and create plans, evaluation tools that really can be effective for the long haul. Last bullet point on this slide, and then we can assess and adjust as we do with strategic plans every 5 years, every 1 year, every 10 years, really making sure that we go back and say, this isn't working anymore. This worked 3 years ago before this new pandemic, but it's not working now. How can we assess and then readjust? Next slide. So oftentimes we think about the first picture, we have spirituality, and we're sort of like this, I'm strong in faith, or I'm a faith leader and I feel strong in where I am, but we're wallowing in things that may be happening. Next picture. Or at the opposite end, we think about this beautiful thing that emerges immediately and expediently that is whole in the midst of hard things. But I'd like to challenge us to think about the last picture, which is that sometimes we come out of these situations, we move forward with these situations. And yes, we've experienced a lot of turmoil, a lot of hurt, but we may be physically or spiritually or mentally different as a result of these situations. So maybe we have impairments that people can see, maybe we have them that people can't see, maybe our community members are moving forward, but they aren't the same as they were before, and that we embrace all of that, but they still have their flowers, so that there can be beauty in embracing this overlap between spirituality and resilience to strengthen members, right? That someone asked, I saw this chat pop up, someone said, does spirituality always lead to more resilience? Not always, right? And so that we can have this connectedness, this intentional connectedness where people can be strengthened in their faith, we can help them foster resilience, and they can move forward with their flowers, even if they are a bit different. Next. So for one of our scheduled panelists, she had this quote, and I think it's really important, that faith is not an antidepressant. It's not just something that we prescribe to others and they move forward and it's like, great job, here we go. Next slide, please. What I want to encourage us to think about from the practitioner side, from the faith-based leader side, as well as in practice within our respective organizations and universities for some of us, that spirituality and resilience can be the vehicle that we use that really can safely and securely take us throughout our journeys with all of the luggage of HIV and AIDS, the luggage or baggage in some regard of COVID-19, the luggage and baggage of racism and discrimination, ageism, sexism, that our vehicles, when they're fostered safely, can hold all of this until it is time for baggage check or baggage claim, until it is time to unload some of the things that we've picked up along the way. Next slide. So as I close, and I will get to all of your questions and comments in the chat, I just want to acknowledge the research team. Thank you all for your collaboration. It has been an honor and a privilege to work with you all. Next slide. I'd love to keep in touch, so I will respond to your messages as best as I can in the chat, but my email address and where you can find out a bit more about my work is also on the screen. And finally, thank you all again for being here today. I appreciate this opportunity.
Wow, Dr. Cherry, thank you so much. I think this was fascinating, new research for probably almost all of us here, and it just offers so much to our understanding. and I'm just thinking you couldn't possibly have known, right, how valuable and important it was going to be at exactly this moment in time. So thank you. What I will do, since we have about 10 minutes before the next panel for Q&A, I will pick some questions from the chat in order to move us forward most expeditiously, I would hope. And Dr. Cherry, if it's okay, since you've just had the floor, I'm going to go right back to you with one question that you started to touch on at the end. This is a question about resilience in communities not only suffering from HIV, AIDS, and COVID, but also in the middle of socio-political crisis. I know in North Carolina, you've been in the middle of some of that. I'm not knowing you, but knowing your location, and issues of racism and violence and some anti-ethnic attacks. I won't go on, but I wonder if you could say a little bit more about how your understanding could speak to people who are dealing with those kinds of traumas.
Yeah, so something that you all may have seen in the literature is we talk about sort of the multiple pandemics, and that's not only COVID-19, right, but racism and inequity. And so how do we, once again, address these in all sectors? I will say that sometimes it may be tempting to say hands off, I'm not going to touch that. But what I'm pushing against and what I'm saying in this presentation is that we have to touch those things. If we are leading people, we have to touch the things that matter most to people in their lives. So for me as a university professor, I have to think about how this is impacting the students that I serve and that I teach, as well as my colleagues. And my church, to someone who asked about this earlier, yes, I do have to think about how racism and anti-racism play out in my church. And so it's an opportunity for us to not only focus in, which is really important, focus in on HIV and AIDS, focus in on COVID-19, but also think about the multiple pandemics that people are battling every single day. And not that we have to be experts, but that we can come to places like this and leverage the resources that are available to us to give people, to equip people with what they need to move forward. So I think it would be unethical for me to only talk about, for example, COVID-19, and to only teach about COVID-19 and to ignore my own personal struggles with racism and discrimination, right? So in summary, what I'm saying is that we can touch the things that matter to the communities we serve, and we don't have to be experts on all of these topics, but I do think we have to lean in and be able to equip them and leverage resources to address them.
Thank you so much. I think you're really exemplifying what I expect most of us are trying to do, which is to bring our personal commitment and personal experience into the work we do. And your work here has just been really inspiring and also just helpful. I have a question now for Danius Puris. Danius, thank you so much again for your presentation. The question that has come through to me so recognizes that under your leadership, mental health was high on the human rights agendas. What can we do collectively and individually as faith partners to maintain this attention after your departure? Do you have any recommendations for us?
Yes, thank you. I think it's a very good moment to strengthen this discourse. It's quite exciting. It's, as I told, there is a search for agreement between those experts, let's say, who would like to continue with status quo, and those who would like to move to next shift of paradigm, which already was happening in mental health care, and always it was some progress with the human rights. So now a lot, I should say, what we need is a critical mass of stakeholders, especially on grassroots movements and NGOs, faith organizations, to liberate this field from legacy of discrimination and coercion. It was too long that common sense was lost in these prejudices. Common sense was occupied by prejudices that, in mental health you cannot avoid coercion. And when these all mental health laws, I have one article which which overrides the human rights of people with psychosocial disabilities, then this article as exception is used in many countries as a rule. So finally, we have a lot of people still locked up and in the name of medicine and psychiatry. So this movement, which is going on now, especially of my allies, were mainly organizations of users, ex-users, and also relatives, also many mental health professionals, some psychiatrists, not majority still, but I think that psychiatry is slowly but understanding that psychiatry itself is hostage to, has become hostage to this legacy, of helplessness, So we should liberate not only people who use and need mental health services, but the entire field. And I suggest that we learn best lessons from HIV movement, that human rights-based approaches is crucial for as a remedy, let's say. So this is to join this movement so that we have critical mass of those who want change.
Thank you very much. I really, really appreciate. I could see nods around the room, the virtual room that we have. Thank you. We look forward to joining with you on that campaign together. I have heard that Reverend Sarah Lund was able to join. Sarah, we're really happy to have you here. What we'd like to do is just quickly go to you and your slides. We have about 5 minutes before we need to go into the next panel, but we would really be keen to hear from you on the tools and resources that you had intended to bring forward. Apologies, I can't see in the room yet where you are, but I understand you're here, so I'm giving the floor over to you and looking forward to hearing from you.
Thank you. Welcome and greetings from the United States. I am in Indianapolis, Indiana, and I serve with the United Church of Christ as a minister for disabilities and mental health justice. And so what I'd like to share with you all are some spiritual care tools that have been developed to help communities. And one of our hopes is that these tools will address stigma. John Swinton is a theologian that I admire for his work in disabilities and mental health theology. And he talks about stigma as stealing our stories, that stigma steals the stories of who we are as fully human. And so these tools really help to create spaces where people can show up as they fully are and share their stories. And this is what we call our WISE tools. And that stands for W is welcoming, inclusive is I, S is supportive, and E is engaged for mental health. And so what we've developed is a curriculum for faith communities to engage in a period of conversation and learning and study about how to become wise. So what does it mean to create communities of belonging that make space for stories so that the stigma can be dismantled? Welcoming spaces invite everyone to show up, but we need to be more than just welcoming. We want to include. And when we think about inclusion, we also think about including in every aspect of our community, including leadership. A lot of times people with various mental health conditions and challenges are excluded. This is ableism. This and that because of a disability or a mental health challenge, they're not capable or able. And that's the discrimination against people who are neuroatypical. So inclusion means in every aspect of our community. And then supportive. If we're going to welcome and include people, we've got to be prepared to support them and to be accessible and to have accommodations. And sometimes that means companioning people, having folks ready to walk alongside. If we have folks with neurodiversity, they might need other ways to process information and to engage in relationships. Another supportive opportunity we've encouraged faith communities is to create spiritual care communities. These are spaces where we can pray for each other and hear those sacred stories, the full story of who we are without judgment or shame. And so we've had a lot of success in our faith communities who create these spiritual circles for people to share their stories. And the last part of this tool of becoming wise is E for engaged. And this touches on some of the policies and some of the ways that discrimination shows up in our healthcare systems, in barriers to inclusion, barriers to education, to employment, and to services. So we want folks to be engaged in the world and in their local communities, contacting elected officials and making a public witness that we are that truly engages all people in the life of faith. And so this spiritual tool of the WISE program is something that we lift up and share with you all and encourage you to take it and adapt it and use in ways that might be helpful for your experience. And again, our ultimate goal is to end the stigma, to honor the whole story of who are created in the image of God. Thank you very much.
Thank you. And I see you're the Reverend Dr. Sarah Lund, so apologies for not having your full title earlier. I really can't say enough about how much I appreciate you both coming, finding a way to get in, and also compressing your presentation to probably half of the time that you had anticipated. So thank you for sharing that. I want to reassure people, I'm seeing the comments, that the materials and presentations will be made available on the website. So you will have access to those after the event. And with that, my time as moderator is up. I need to hand the floor over to my co-moderator, Reverend Dr. William Francis, who will lead you through the next part of this webinar. And it's a delight to hand the floor over to you, Reverend Dr. Francis.
Yes, Laura, we thank you so much for just guiding us over the last hour. We're looking forward to this next hour. What great presentations and information that should lead to transformation for us all that has already been shared. So going into the second section, we are going to be looking at best practices and lessons learned around HIV and COVID-19. Again, my name is Reverend Will Francis, senior leader here at the Hub in Atlanta, Georgia, and very excited to be here today. We are an integrated care ministry, and we do well without walls, meaning that we are not confined to the four walls of a space. We literally set up a roadside to do ministry. And our mission is really just going into this conversation because we transform ministry minds, lives, and souls in order to change communities in the world in which we live, work, play, and worship. And you'll notice that that last sentence is really our ode to public health, because as a faith leader, I saw that my work in public health was going to be just as important. And we realized early on that there was an intersectionality between our faith and spirituality and the social determinants of health that we have talked about earlier today. Unapologetically, we have come to be known the church that does communion as well as condoms on Sunday morning, as well as needle exchange. And, I have to say that it's unapologetically because a lot of times we want to challenge theology. Well, our theology is very simple. We have to save lives as well as save souls. So it has taken me out of my comfort zone as a faith leader, but we have so many testimonies and stories that we would share working with those around food insecurity and homelessness, poverty eradication, economic mobility, as well as human sex trafficking. So I've taken so many notes today. I'm really interested in what we had talked about in reference to mental health and trauma as we look forward to creating a healing-centered environment. So we'll get to that conversation. We want to encourage folks to put your questions in the chat. Again, as Laurel had said, the notes will be provided on the website, so you can go over and get all of these great presentations. But it is my honor here today to guide you through again this next hour. And our presenters, we have four. I'm going to introduce the two, and our first presenter will be Gracia Villetta, president of the Bolivian Network of People Living with HIV. And then she will be immediately followed by Nakatha Nuro, coordinator of the African Christian Health Associates platform. So we'll go ahead and pull up the slides and turn it over to our next presenter. Gracia.
Thank you very much. I'm going to be making this presentation in Spanish. That's what UNAIDS asked me, so please prepare your interpretation. Bueno, gracias. La próxima, por favor. La próxima. Ok, gracias. Yo, para hacer esta presentación, me hice una pregunta. ¿Cómo sobrevivir al VIH y al COVID-19 y ser feliz? Suena una pregunta un poco fuera del lugar, pero sí creo que es posible sobrevivir a 2 epidemias. Voy a presentarme primero para que me conozcan. Soy antropóloga, tengo estudios de posgrado en género, salud sexual y reproductiva. Soy de Bolivia, tengo 23 años y 21 años. De esos 43 estoy viviendo con el VIH. Sobreviví a la violencia sexual por parte de 2 desconocidos cuando tenía 20 años y recientemente a la violencia física y psicológica por parte de una pareja. Me adscribo a la fe cristiana evangélica y en resumen, ¿qué puedo decir? Para mí la vida no es fácil, pero puedo decir que vivo cada día plenamente. Ok, interpreter. Algunas personas podrían preguntar, pero ¿cómo realmente se puede sobrevivir a 2 epidemias? Bueno, la primera respuesta es vivir. Hay que ponernos en la tarea de vivir. En los 21 años que vivo con el VIH, conocí a muchas personas que lamentablemente murieron muy jóvenes, especialmente antes que tuviéramos los medicamentos. Una vez que los medicamentos estaban disponibles, lo que marcó la diferencia entre los que vivieron y los que no fue la capacidad para vivir bien el día de hoy. Desde que personalmente yo recibí mi diagnóstico positivo al VIH, yo me adscribí a este lema que lo puse en rojo en la diapositiva. No puedo cambiar mis errores del pasado, solamente aprender de ellos. No puedo controlar el futuro, solamente planificarlo. Lo que tengo es el día de hoy, por eso se llama presente. Y viviré este día como si fuera el último de mi vida. Y sin pensarlo, así pasaron 21 años con el VIH sin nunca haber enfermado. Yo puse a la derecha de la pantalla este texto de Mateo 6:34, donde tenemos unas hermosas palabras de aliento. Dice, así que no se afanen por el día de mañana, porque el día de mañana traerá su propio afán. Basta a cada día su propio mal. Quizás a veces vivimos tan consternados por el futuro que dejamos de vivir el día de hoy o sintiéndonos tan culpables por el pasado que no nos concentramos en el presente. La próxima, por favor. Otra clave para vivir en medio de 2 epidemias, perdonar. Entre los hijos adolescentes de las personas con VIH, observé 2 tipos de personas. Los que quieren estudiar medicina para sanar a sus papás y los que odian a el otro padre porque transmitió el VIH, especialmente a los padres varones que transmitieron a las mamás. Y yo me ponía a pensar, todas las personas podemos contar ofensas que seres queridos y aún familiares han hecho contra nosotros. Tenemos infinitos testimonios de eso. Pero para sobrevivir a pandemias y a todo tipo de crisis, necesitamos perdonar a las personas que nos ofendieron. A la derecha de la pantalla puse un poco de algunos datos de cómo la ciencia ya ha determinado que la falta de perdón modifica nuestros pensamientos, sentimientos y también la química de nuestro cuerpo. Es decir, que cuando no perdonamos, nos enfermamos más. Entonces, la primera persona liberada al perdonar somos nosotros mismos. Y esto no quiere decir que no tomamos en cuenta la ofensa, sino que ya no somos esclavos de lo que nos pasó. Hay mucha investigación sobre esto. Yo solamente puse acá unos datos que la compartieron en una cumbre de capacitación ministerial. La próxima diapositiva, por favor. Otra clave para sobrevivir 2 epidemias, amar. Las situaciones de la vida pueden ser muy desastrosas, al punto que podríamos morir de la tristeza con cada noticia que escuchamos. Hay problemas, hay guerras, hay inundaciones, hay lluvias, hay epidemias, hay problemas de terrorismo, hay inestabilidad política, hay pobreza, etc. Pero nosotros tenemos que decidir deliberadamente amar. Por mi fe, yo digo amar a Dios, amarse a uno mismo, viéndose como una criatura de Dios hecha a su imagen y semejanza. Esto va a implicar que vamos a ser responsables con nosotros mismos, priorizarnos. Y amar a la familia, y no estoy hablando de una familia en el sentido tradicional, sino que hay muchos tipos de familia, porque aquí alguien puede decir, pero no tenemos familia, muchas personas, y es verdad, pero hay familias que armamos, hay familias que escogemos. Y en el otro lado puse un texto de Efesios 2:10, donde tenemos un texto hermoso que nos dice que somos hechura suya, creados en Cristo Jesús para buenas obras que Dios preparó de antemano para que anduviésemos en ellas. Somos una creación de Dios. Y si nos empezamos a ver de esa manera, creo que nuestras acciones van a seguir en consecuencia a esa identidad. No somos cualquier cosa, somos una imagen hermosa, una creación de Dios, y por lo tanto merecemos lo mejor. Conozco mucha gente que no se ve a sí misma de esta forma. De hecho, se ven como algo despreciable, detestable, como, digamos, la basura del mundo, y es ahí donde comienzan muchos problemas de salud mental. Mucha gente dice, yo no valgo, no sirvo, y por eso prefiero morir. Pero si empezamos a vernos como una creación de Dios, es como que somos una obra de arte, como una hermosa joya. La próxima diapositiva, por favor. Otra clave para sobrevivir en 2 pandemias, decidir ser feliz. La felicidad no es eterna, las circunstancias pueden empeorar, pero nuestra actitud debe ser la de decidir, tomar una decisión para ser feliz. Y esa decisión implica escoger las cosas y quizás también las personas que nos hacen felices. Esto no es una excusa para el libertinaje, sino para proveernos a nosotros mismos de lo necesario para vivir bien, no solamente arrastrar la vida a cuestas, sino vivir bien. Y hay un texto hermoso en Proverbios, en la Biblia, que nos dice que el corazón alegre es buena medicina, pero por otro lado, el espíritu quebrantado, o sea, el espíritu triste, seca nuestros huesos, nos enferma. Yo sé que las condiciones de las vidas que vivimos pueden ser muy tremendas, muy terribles, pero a pesar de eso tenemos que concentrarnos en tomar una decisión de ser felices, porque eso es por nuestro bien. La próxima diapositiva, por favor. Otra clave es ser responsables. Una señora en Bolivia me dijo, los que se cuidan más de COVID se contagian más. Esa fue su respuesta cuando yo le pregunté por qué no usaba barbijo. Y yo digo, en este punto de la pandemia de COVID y de la epidemia o pandemia de VIH, conocemos qué hacer. Sabemos cómo prevenir la transmisión de VIH, sabemos cómo prevenir el contagio de COVID y cómo cuidarnos si es que adquirimos estos virus. Y tenemos que hacerlo. A menudo me sorprende que algunas personas dicen, ay, me contagié de COVID luego de una pequeña reunión familiar con unos pocos tragos. Obviamente que eso iba a pasar. Y ahí puse un recordatorio de la OPS, la Organización Panamericana de la Salud, que nos recuerda 3 cosas básicas para prevenir el contagio de COVID. Es decir, yo quiero llegar a la conclusión que si no hacemos las cosas que sabemos que tenemos que hacer, vamos a tener problemas. Entonces, una manera de evitar situaciones complicadas y por lo tanto que desmejore nuestra salud mental es seguir las normas que nos han dicho. Si nos han dicho que tomemos el medicamento para no enfermar, si tenemos VIH, hay que tomarlo. Si nos dijeron que hay que usar el barbijo, mantenerse en aislamiento para no contagiarse de COVID, hay que hacerlo. La próxima, por favor. Tener esperanza. Últimamente, en este tiempo de la pandemia, escuché a mucha gente que dice, ¿para qué seguir la vida? ya nada importa, si todos nos vamos a contagiar, de algo hay que morir. Y como decía hace un momento, no se trata de arrastrar la vida como un bulto pesado y una carga. Los que seguimos vivos tenemos la responsabilidad de vivir bien y vivir felices. Para mí, desde mi experiencia, puedo decir que es necesario aferrarse a Dios porque Él tiene una esperanza sobre el futuro. Nosotros no podemos ver el futuro, pero Él sí. Y hay un texto maravilloso que lo puse al otro lado, que está en Jeremías 29:11. Dice que Dios tiene planes para nosotros de bienestar y no de calamidad, para darnos un futuro y una esperanza. Si en la vida humana que tenemos no vemos esperanza, yo personalmente he encontrado la esperanza en Dios. La próxima, por favor. Y esta es la última, agradecer. Escucho a muchas personas, y no solamente en tiempos de pandemia, que solamente tienen quejas, ¿no? Que no tengo esto, que no tengo aquello. Y entonces, claro, si nos concentramos en lo que no tenemos, siempre vamos a estar mal. Pero si comenzamos a cada día contar una cosa por la cual estemos agradecidos, estoy segura que vamos a poder tener muchas cosas por la cual sentirnos felices. Hay una práctica hermosa que ustedes seguramente la han visto, se llama el frasco de la gratitud. Se trata de poner una cosa por día en una pequeña botella por la cual estamos agradecidos. Pueden ser cosas tan sencillas como poder despertar, ver, poder cocinar, un alimento que nos vamos a servir. Les aseguro que ese frasco se va a llenar y al final de una semana vamos a darnos cuenta que tenemos muchísimo por lo cual agradecer a pesar de las circunstancias adversas. Esta es un poco de la experiencia que yo pude recolectar en estos 21 años viviendo con el VIH y creo que sí se puede aprender a vivir con un virus. Las condiciones pueden empeorar, pero si tenemos estas perspectivas, vamos a tener esperanza y vamos a atravesar esta situación tal como lo hemos hecho con el VIH. Muchas gracias.
Wow, that was absolutely awesome. And we thank you so much for so many just life nuggets. Bios are available on the website, but I think that presentation just really showed us, your purpose in life. And I thank you personally for those many things that you said that I know I just jotted down for personal use and for all of our use, really, just getting through day to day. So now we're going to go ahead and key up Nakatha Nuro's slides. Again, coordinator of the Africa Christian Health Association's platform, and she's going to share best practices and lessons learned. You there? Good afternoon to you.
I'm here. Thank you very much. And I'm happy to be here. And thank you, Gracia, for setting the platform to discuss what our experience was since the start of the COVID pandemic early last year. Next slide, please. So the Africa Christian Health Associations platform is an organization that works with Christian health associations and networks in sub-Saharan Africa. And next slide, please. We work, the Christian health associations are organized as mission health facilities and organizations nationally in their different countries. We are in 32 countries, about 43 networks. We facilitate we facilitate networking and communication. We also do joint advocacy, capacity building, as well as partnerships building with our membership. So next slide, please. So thinking about mental health and spirituality and what our experience was, definitely there was panic from a lot of us at the beginning of the pandemic. And for a lot of Africa, we listened to news on the pandemic from a point of it's not yet here, and we were not sure if it's coming to us, but then it did, and we needed to respond. And here we were as a church and church health system. We had to think about what to do, and a lot of it was reaction. We went through a period of not having supplies. We went through a period of panic, anxiety. In terms of mental health, the caregiver, being the healthcare worker, There was anxiety, fear of infection, burnout because of the patient load. They also needed to care for the caregiver. Gracia was talking about the patients. We had the HIV patient who we've always talked to about the need to make sure they stay on their medicines and not miss their doses. And now it was time we didn't know how to get the doses to them. They would not be able to attend their appointments. And also the family and the community at large. There was confusion at that time and we didn't know where to start. So we started to think about what role do we play? And the first place the first things we did in our response at the beginning of this was to work with our religious leaders. We are often talking about communities, and the communities are as informed as their leaders, and religious leaders are gatekeepers in a lot of our communities. And we are Christian health associations, meaning that we have an association as well with the churches. So we started by reaching out to the religious leaders. Governments closed churches in many of our countries, and that added to the confusion because as far as a lot of the people in Africa know who subscribe to religion, is that in times of difficulty, one of the places you reach out to is to the church. And then the church was closed and the religious leader was not sure what to say about why the church is closed. So the first thing we did was to start thinking about what messages, what information do we need to give to the religious leaders to make sure that the religious leaders are well informed to help the church or their congregants understand why the physical building known as the church is closed, but that they can continue being the church even without the physical building being there, and what kind of messages do they take out. So there was quite some work in terms of the church taking the role of the healthcare worker, and the healthcare worker also taking the role of the church. The photo I have there is of, this is Uganda, and religious leaders were oriented on COVID-19, and churches were required to also have some measures that included taking temperatures before churches were reopened or during services. So that's part of the training that was there. Next slide. That's in Cameroon. That's the usual morning devotion that the health workers have in the morning before they start work. Next slide. So I've talked a bit about some of these things and some of the reasons why there was a lot of issues in Africa, in many places in Africa. We are used to congregating, going to church. We go to the funerals, we go to the weddings. We want to be there in funerals and in weddings, which are conducted by the religious leaders. When people are sick, we want to actually visit. When we meet with somebody, a handshake is part of greeting. A lot of people use the transport system that is public. When I go to a clinician, I want them to examine me and touch me for me to feel that they have actually seen me. Then there was issues around quarantine and isolation, including how do you isolate in houses that might not have the amount of space that would help you to isolate well enough and be in your own space as we're advising. And then there was a difference in disease prognosis. Some people were getting better, others were not. So what exactly were we going to tell people? So those were all issues that surrounded the mental health issues that were there with the caregivers, as well as the patients themselves. Next slide. Those are just photos of some of the things that we did was deliveries of medicines to patients at home to help ease the anxiety. So next slide, please. So I'll talk a bit about the lessons. So one of the things we did was putting people first and caring for the caregiver. So we had online counseling sessions. with mental health professionals. So some of our members, or some of them, organized sessions where they were able to reach out to the caregiver. Then wellness sessions we were able to do, including exercise, because people worked long hours, people were stressed because of the queues at facilities, so exercise. And then providing supplies. We tried to make sure that people had supplies that, even if it was, the logistics were very hard, but to the best way possible, we tried to provide supplies with support from partners. Then where work did not necessitate the need for physical appearance at the office, we advised our members or people to use flexi time and telecommute, and then also provide psychosocial support during isolation or quarantine. And then also in the community, we worked with the gatekeepers, religious leaders as champions for the response. It doesn't mean that the religious leaders were also not going through the same thing the community is going through. They had their own anxieties, they had their own fears. So we have to start by working with them and helping them to be able to work with their own fears and anxieties, and then be ready for the community. Then appropriate messaging, making sure that people are well informed. We stayed on the WHO website. I know there were changes in advice from time to time, but we stayed on the WHO website and made sure that we updated members with information as we received it, and advised on what kind of things that they needed to do. We also worked on capacity building, because people did not know what to do when a patient appeared at the facility. They didn't know what to do if they suspected that the person was COVID positive. They didn't know what to do if the HIV patient came to hospital and said, I didn't get my drugs and this is what I'm feeling. So we needed to make sure that people's capacity was built. Then crisis management, considering new and better ways to prepare for circumstances. There are a lot of things that we have learned with this pandemic, and we are now discussing how do we prepare for the next pandemic. Beyond that, how do we even prepare? There's a lot of anxiety around the vaccine. How do we prepare for that? How do we help communities and even health workers and caregivers to be better prepared for the next pandemic, as well as the vaccine and things that are coming up? Also, how do we embrace technology? We are now holding conferences online. We are able to better reach out to our members and countries and hospitals and caregivers through technology. And also, how do we make sure that we connect with strategically? For example, there's still a lot of information on the vaccine that we are trying to seek out. So strategic partnerships to be able to get the information that we need to pass along to people that are actually working with communities, so that they are well informed. Otherwise, and this is the time, especially for the vaccine, we need to make sure that we have information to pass on to people, so that when the vaccine is finally in many African countries, the reception will be good. Otherwise, as is, people are continuously anxious. They do not know if they should take the vaccine or not. And so we have that as part of our responsibility. Next slide. So this is actually my last slide of a community health workers in Uganda who are exercising or being taught how to exercise as we talk about non-communicable diseases and COVID. So for us, the pandemic has been a time of learning. We continue to learn, but we think that it's time for us to sit down and look at how do we prepare for the next pandemic? What are the lessons we have learned to be able to prepare for the next eventualities? Thank you very much for the opportunity.
No, thank you. Thank you. We have several questions that are coming in through chat, and we will get to some of those. But one quick question for you. How did you reconcile challenges between denominations, or was it really the same information that was presented across denominational lines?
So we work mostly with, especially when we have to deal with issues on theology, we work with theologians that help us to be able to work on information so that we are able to share information that is appropriate. So that's how we do it.
That's great. That's a lesson learned there. Oftentimes we try to figure out what needs to be done versus just asking people what we can do. So I think that was great. And your other comment about community knowledge and leader knowledge, I thought was a great comment as well. So we thank you for your presentation. We do have plenty of questions that are coming in. These slides will be on the website for you to go back, but some great conversation thus far. We want to go ahead and keep moving. It's 10 o'clock. We want to be just respectful of everyone's time today. So our next two presenters are going to be, I was given the name Apple, so I couldn't mess that one up, but I think it's Applesta. I think I said that correctly. I heard it earlier, which is the program lead and psychosocial support for innovations in mental health, Human Touch Foundation there in India. And she will be followed by Father Rick Bauer, Director of Spiritual and Psychosocial Support for the Eastern Deanery Age Relief Program in Nairobi, Kenya. And he'll be speaking on spirituality, mental health, and resilience during a dual pandemic of COVID-19 and HIV. And again, we're looking at lessons learned and best practices. So Apple, I'll go ahead and turn the floor over to you.
Thank you for the introduction, Reverend Father Will. My name is Applesta Meren Da Costa, and I'm the Psychosocial Program Lead at Human Touch Foundation. And today I'll be giving a brief presentation on optimizing health and non-health outcomes for adolescents living with HIV amidst the COVID-19 pandemic. Can I have the next slide? So to give you a brief about our organization, Human Touch Foundation is a non-profit organization that works in the state of Goa, India. It works with the youth and for the youth. Our mandate areas of work include sexual and reproductive health, HIV, tuberculosis, and substance abuse. So whatever services that we render to our clientele, they are strategically tailored in such a way that it ensures that all young people have access to good health, well-being, and human rights. Next slide, please. Under our strategic area of HIV and AIDS, we have two main programs, which is the WeCare program. Under the WeCare program, we focus on addressing barriers that hinder adolescents living with HIV to receive an optimum level of quality of life while living with a manageable but chronic illness. So under this program, we cater services that include giving appropriate information about HIV, guiding them to engage in health-seeking behaviors, and also advocating for their rights by engaging in major stakeholders. Our second program is Positive Steps. It is basically a harm reduction program that focuses on needle syringe exchange, oral substitution therapy, condom distribution, and behavior change communication methods. We do this in order to reduce the risk of contracting and transmitting HIV and hepatitis C virus among the users. And we also engage in conducting screening tests for both the diseases for early detection and treatment among people who inject drugs. Next slide. So when the pandemic was there, the sudden enforcement of COVID national lockdown increased the burden of anxiety in adolescents living with HIV. And this was especially because adolescents living with HIV majorly came from, already socioeconomically disadvantaged background. And some of the concerns that gave rise to anxiety and stress and depression among these adolescents was the availability of ART medications, food security, and livelihood as a whole. Now, during this period, it was, very important to prioritize innovations in mental health care and other services that we render to HIV positive adolescents, because all of these issues was, worsening the mental health among these adolescents in comparison to the general population that we saw. Can I have the next slide? So the COVID-19 pandemic had devastating effects on the mental health of adolescents, as well as it downstreamed HIV-related treatment outcomes, especially because they had limited access to HIV-related services. The services were available, but most of this population depended on public transport, which was not available during the lockdown. And because of this, they were not able to access these services that were very important for their health. And also, it was all of a sudden there were containment measures that were put, and just being confined within four walls of their homes, not being able to do anything, go anywhere. There was so much of isolation and things like that, and especially there was economic instability, because a lot of these families lost their jobs and were unemployed, and these adolescents come from families that depend on daily wages, and having no savings in hand, it was very difficult for them to get access to even food and other basic necessities that was needed. Can I have the next slide? So besides health related outcomes, there were other concerns that came into a picture, and this was again because of unemployment, and a lot of these families stay in temporary houses where they have to pay their rent on monthly basis, and having no savings, there was a fear that would they be thrown out of the house, would they be homeless, especially during the pandemic, which was very stressful. And also there was a lack of knowledge and information that was among these adolescents, because there was so much of information on the internet, on TV, and no one, like, they did not know like what was the appropriate information that they had to keep in mind. And also among the pandemic, the vulnerability of children and young people having HIV worsened, because there were school closures, and they were just at home, not doing anything 24/7. It was being confined in their houses. And also there was an interruption when it came to having access to education, because they did not have the necessary gadgets that was required for online education. And what happens in India is that we have something called as the midday meal scheme, where adolescents and children going to schools have access to their meals, lunch, which is free. And when this was not there during the lockdown, it added additional pressure on the families. Next slide. So amidst all of this, we adopted something called as the Bio Psychosocial Model. So while addressing the needs of an individual, it was equally important to first assess all the aspects, that is the biological, the social, and the psychological, in order to to help the client to reach an optimum level of quality of life. Hence, at Human Touch, we adopted a Bio Psychosocial Model, which I will be talking about in the next slide. Next slide. So our first approach was leveraging social protection systems for these adolescents and young people. As stated earlier, the pandemic, majorly affected the livelihood and of the adolescents and their families. And Human Touch Foundation under the Social Protection Program helped link clients to various government schemes and pensions that were available. And we saw that linking clients to social protection increased the household budget of the family, thereby easing their pressure. And apart from this, Human Touch also, with support of its benefactors, helped beneficiaries to procure admissions for higher education when they were not able to. With everything going online, with education transitioning to online teaching, beneficiaries were facing a lot of challenge because they came from low, poor income setting families, and they did not have access to IT devices. And after doing appropriate assessments of who requires what, we were able to provide some of the gadgets that was needed for online learning for some of the beneficiaries. Another thing that Human Touch did was, observing that a lot of these young people living with HIV were unemployed and at home, doing nothing. Numerous entrepreneurship and skill building programs were organized for the beneficiaries, and this acted as a platform for learning and further personal development. The next slide. The second approach that we took into consideration was strengthening the food security, and keeping in mind the economic impact that COVID-19 had. A lot of these adolescents living with HIV had to compromise on their nutritional intake. And food insecurity subsequently affected the physical as well as mental health of the individual. And to address this vicious cycle and also to promote healthy diet, Human Touch Foundation, with the help of some of the sponsors, like from the UN agencies and faith-based organization and even individual donors, we were able to provide access to nutritional food items and immunity boosters to around 200 households. And this also helped them to retain to care and treatment, which would prevent adverse mental health outcomes. Next slide. The third and most important approach that we engaged in was investing and innovating in emerging mental health crisis. And in order to tackle mental health crises that were rising amidst the dual pandemic, we engaged in a hybrid model of care, where we adopted telephonic counseling as well as in-person counseling. We realized that not all our beneficiaries were comfortable with telephonic counseling, and so as COVID-19 safety protocols were brought into action, we slowly started in-person counseling while keeping telephonic counseling in hand. And it is observed that adolescents and children who start taking ARVs from a really young age, these medications, it hinders their cognitive growth. And for the same reason, we at Human Touch simplified therapy, so that it has a greater impact and a greater outcome. So here we use an eclectic approach where we integrate different techniques from different psychotherapies And we tailor the intervention in such a way that it caters the issues and suits the requirements of all the clients. So the psychotherapies that we use to address mental health issues like stress, anxiety, depression, behavioral and interpersonal issues that came up, fear, feelings of isolation, so on and so forth that arose due to the pandemic. Next slide. So coming to the recommendations, it is always recommended that before starting any therapy, we need to use screening tools that are readily available online, so that we have a standardized interpretation of the current functioning of an individual. And so assessing using screening tools will not remove the mental health issue altogether, but at least it will help reduce the impact that it has on an individual. Next slide. So our next recommendation would be that we engage in person-centered care program, where we involve clients in the decisions making that pertains to their own health. And it is also very important because it will help them to motivate and voluntarily participate in the therapeutic sessions. And therefore it will have a positive outcome from therapy sessions. Next is engaging family and caregivers. So family members and caregivers of the individual who has mental health issue needs to be encouraged to participate in the therapeutic process, because this constitutes as an integral source of psychological support for the client who is in therapy. And it also leads to better recovery. And it is also important to psychoeducate the family about the illness so that they have appropriate knowledge about it. So when there are symptoms or there is any unusual behavior that the client engages in, they know how to respond and react to it appropriately. And another thing why family members and caregivers need to be involved is because they also need support for the emotional fallout that they have because of the additional responsibilities that they have to take of the client. Last, we recommend that appropriate referral links need to be established because healthcare professionals should consider that when a service that is required by the client, which the client seeks, and you're not able to cater to those needs, it is beyond your expertise, we need to understand that referrals should be made either to a psychiatrist, a doctor, maybe even to support groups, because ultimately what we want as health professionals is what is best for the client. Yeah, so with that, I end my presentation. Next slide. Thank you. And for any queries, you can get in touch with us on the contacts.
Well, I want to thank you for, there was just so much meat that was in that presentation. We thank you for the work that you are doing. And I'm sure if anyone has any questions or needs to have further contact with Apple, the presentation will be on the website with her contact information, also Facebook and Twitter, that you'll be able to contact her and her organization. So we thank you for that presentation. And we'll now turn it over to Father Bauer.
Great. Thank you, Will. It's terrific to be here. It's horrible going last because there have been such great presentations with great information, and I'm almost going to try to summarize and repeat some things, but also to talk a little bit about what we're doing at Edarp. I also bring this as I spent Tuesday at the IAS COVID prevention webinar, and I could not, for 6 hours, could not get any of them to mention faith, or maybe faith had a role in COVID prevention. So it's a delight to be here where we can talk about the bio, psychosocial, and I believe spiritual combined method to intervene on these pandemics. Next slide. Now, having said that, most of us here are coming from, a place of faith. And we realize and we know from our own experience that faith can positively impact a person's physical health, mental health, and well-being. But if there's a possibility of a positive impact, then we also have to realize that faith, religion, spirituality can negatively impact mental health, physical health, and well-being. And we need to be honest about that as people of faith, as we explore these really complex relationships between faith, mental health, and resilience. Next slide. I really appreciated Dr. Sherry, and she had some great definitions, and I think we need to really focus on some definitions. And so here's one that I'm using here at Edarp, when we try to understand what is this spirituality. And I think every human being is spiritual. And as Dr. Sherry said, they may or may not be religious, but everybody looks for that meaning, purpose, transcendence. And as our first speaker said, that relationships defines not only mental health, I think relationship defines spirituality. That I see spirituality as anything and everything that brings meaning, purpose, and connectedness into our lives. And that's connectedness with higher power, God, that may be, and as well as each other. That can be connectedness with the universe. And our spirituality is expressed through beliefs, values, and practices. Next slide. No one that I've heard has really defined mental health. And so I, of course, went on the UN WHO website and just cut and pasted their definition that mental health is that state of well-being, like that we can realize his or her, our abilities, we can cope with the normal stresses, we can work productively and make a contribution. It's linked to how we think, how we emote, feel, and how we, again, relationship, interact with each other and earn a living. I personally kind of had a little problem with this focus on, earn a living and contribution. Absolutely, employment and during COVID has reminded us how important this is, but it seemed that this definition is a little ableist, that there can be people with significant mental, cognitive, physical that may not be able to make a living, but may have good mental health. And so I think WHO, I think we need to maybe struggle with this definition of mental health. Next slide. And we need to define what is this resilience that we're talking about. And again, Dr. Sherry, I loved your slides, that ability to bend but not break, to maybe bounce back as we face these adverse life experiences, the lockdowns, the stigma from COVID, the stigma from HIV. But I like that the American Psychological Association says that this resilience is this ability to adapt well in the face of adversity, perhaps trauma, tragedy, and significant sources of stress. But what we don't know about resilience, is this a trait? Is this a process? Is this a research outcome that we're looking for? And in my experience and in my research, I think there's a danger of looking at resilience as binary. Either it's there or it's not. And if I just look at my own personal life in the last 12 months, there have been days my faith, my mental health has been good. I've been able to be resilient and to support my staff at Edarp. And there are other days where I have been a living mess. And so I think we just need to be honest that maybe resilience is much more on a continuum than it is here, it's there, or it's not. Next slide. I want to talk a little bit about a tool that we in chaplaincy use, the RCOPE, the religious coping, that's kind of a 14-measure way to look at how a person's religion, much more so than their spirituality, helps them cope in situations, and especially in palliative care and in healthcare situations, and the role that religion serves in trauma, crisis, and I think, Sherry, you mentioned in those transitions. Next slide. So it was developed, and I'll give you all the where you can get more on Ken Pargament's program. And Ken looked that there are some people that have positive religious coping mechanisms, and there are people that have negative religious coping mechanisms. And I want to say that this is not judging. Okay, I don't want to judge someone's faith or personal spirituality, but I want to understand it. I want to understand how maybe a particular way of religious coping, spiritual coping, can negatively impact adherence to HIV medicine, using masks and other COVID prevention. And so Ken looked at both of these, not to judge people, but to understand people. Next slide. So what does our faith, what does our religion bring out in us? Does it bring out the best in individual and reinforce problem-solving behaviors? Or does it encourage a negative avoidance? We at Edarp had, a period where people were going off of their ART medications and saying that I want to believe that Jesus will heal me. I'm going to pray. And we actually had deaths from this. So again, I want to understand where a person comes from. Next slide. So these are some of, this is the brief RCOPE, there's also an extended one. And this is a research tool, but I often use at least these ideas to better understand, not judge, but to understand where a person may be coming from. That people that look for a stronger connection with God, look for God's love and care, ask God to help them let go of anger and resentment that my friend and my hermana Gracia talked about. Having God let go of that can be so healing. Can we see how God can give us strength in this COVID? Because the one thing that I learned on Tuesday from Dr. Fauci and others is this ain't going away. In fact, some of the people were saying that 2021 is going to be worse than 2020. That drove me to tears, but this is where our faith, our spirituality can help us. The negative coping skills are when people wonder if God has abandoned them, if God is punishing them because they're not doing the right kinds of devotions or praying in the right way. I'm wondering what I did that God is punishing me, wondering if God loves me. I'm wondering if my church has abandoned me. I'm wondering if Satan or the devil, questioning this. And people that have strong negative coping tend to have also negative outcomes in mental health. So a little bit now about, next slide. Those of you that know me know the Edarp guide. And this is the guide that I have used in my 39 years now of working with people with HIV. And I think it combines the spiritual and the mental health. Every day, spend time with God. However you understand that word. If it's God for you, great. If it's nature, if it's Krishna, if it's meditation, if it's delving into your sacred texts, if it's taking a walk in nature and understanding the universe, spend time with that transcendent, you, every day. Number 2, take care of each other. Edarp has 420 employees, and I think we've dealt with these 2 crises by me telling people, and I know there's some Edarp people on this webinar, take care of each other. Check in with those that you work with every day. How are you doing? And then take care of the patients. Repeat and never change that order. Next slide. And so some of the things that I've done is using, and some of you mentioned some exegesis, delving into our sacred texts and sacred scriptures. And I developed these 5 to 6 slide PowerPoint Edarp praise, looking at a different text. Where are we and how do we strengthen ourselves? This is taking care of the staff. We use system-wide emails and we'll now closed WhatsApp groups for both staff and clients. In our 14 clinics, they use daily devotions, with proper physical distancing, reflecting constantly on the spirituality and mission of our work. And I'm almost done, and I know our time is done. Next slide. Using art. And some of these things that my colleague from the African Council of Health said, yes, some of our churches are closed, but church online was not canceled. And some of our small Christian communities using WhatsApp groups to stay connected. Quiet time with God, however you understand that, isn't canceled. Praying for the sick isn't canceled. Checking in on each other, helping others. Being church is not being canceled. And so we need to continue all of this. Next slide. And you can see this. This is an example from the United Church of Canada, a beautiful prayer that's very Christian, but my Hindu friends have adapted it to theirs, of prayers you put on the mask, that we're using our faith, our spirituality to integrate into good public health interventions. Next slide. And though there's some resources, some of you have already mentioned them, on how do we get spirituality and health, spirituality and COVID. The next slide. And if you're interested, you can email me. You can check out my Twitter feed. I do constantly on spirituality and health. And an organization that I'm part of, the Global Network on Spirituality and Health, is at George Washington University in Washington, D.C. And you can check out the Jinsa Asante, and thank you.
Father Barrow, great presentation. So much, again, meat that was there. And I love the mask idea to send a message. I was just reading some of the prayers, and I think that was great. And there are, as you said, some downside of being last. We have some great questions that came in for you. So I do hope that you all will join us on the Interfaith Health platform. We're going to open up the chat tool. Although the presentations are done, I think the conversation is just beginning, or at least needs to continue. So I'm going to see if Laurel, are you still there? I wanted to at least bring you back on as we go to close out. I don't know if there is any other housekeeping that we need to do, but we are definitely going to continue the conversation on the Interfaith Health platform. We're going to open up that chat tool now. I know we had a question about hope in God as compared to hope in self, and then what do we say to those that think that COVID and HIV and mental health are spiritual issues only? And I want to continue that conversation. I've always said faith without works. Sometimes you have to work with your doctor, you have to work with your pharmacist, your dietitian, your financial counselor, your marriage counselor, whatever will get you through, combined with the spirituality and faith. So we want to continue that conversation using the chat tool in interfaith health platforms. Laurel, anything that we have forgotten?
Well, I'll just come in briefly. Thank you so much. I just want to say some quick thanks. I really want to thank all of the speakers. This was tremendous. We could have listened to you all day, I think. So really, really grateful for you. I also want to thank our interpreters for doing their brilliant work at simultaneous translation, a skill that I think I'll never learn, but I really am grateful for. Reverend Francis, really, I want to thank you for your wonderful leadership in guiding this session. So thank you for that. I want to thank
later than anticipated, but we'll be okay.
well, that's just because we need so much more of this than we're able to have. I think that's all that it reflects. I also want to thank the UNAIDS PEPFAR Faith Initiative that helps us fund and present some of these kinds of webinars. I invite everyone here to join us for the upcoming webinars that you can find information on the website. And finally, I want to thank my team at UNAIDS, our team at UNAIDS who put this together, Jacek and Francesca and Julianne, who've just done remarkable work. And I hope I haven't forgotten anyone. I guess I should thank the participants as well, because the dialogue in the chat, even if we haven't been able to have it in person, I think is outstanding and rich and takes us forward really, really well. So just want to express real appreciation to all of you. Thank you. And Dr. Francis, really thank you.
No, thank you. We already have the presentations on the Interfaith Health platform. Upcoming webinars, April, we'll be doing migration and HIV. In June, the role of faith communities in strengthening adolescents peer groups. And then in September, framework for dialogue and stigma reduction interventions. Going into December, talking about World's AIDS Day and doing an interfaith service. And the conversation is not only on the website, but also on the Facebook page for Interfaith Health platform as well. And it was my pleasure to join you all, literally from all across the world today, to have this very important dialogue. So I thank you.
Thank you, everyone. Please be safe and well.
Be blessed.
Thank you.